How can you expect people to keep up with it? Not only that, but the white paper talks about this lethal lag time, the delay between when new research that could save somebody's life is completed and the time that it's actually been read by doctors after publication. And in fact, there's another lag. Some people have said it's up to 17 years from the time a research idea occurs until the results are in use in practice. So lives are at stake. Docs are squeezed for time. What do? I'll tell you, a doctor may not get paid for doing research or doing email or phone calls or whatever, but I had all the time in the world to dig deep. And that's what you find in patient communities. I had nothing better to do with my time, let me tell you. That's the 1% for patients. Tom Ferguson put together this slide, which is about industrial age medicine, showing the top of the pyramid care. He called it industrial age medicine because, the ability to create values belongs to those who create the means of production. And what he foresaw at the dawn of the web was information age medicine. This is what he foresaw when the web was new. We have individual self-care, friends and family, and then self-help networks like ACOR, professionals as facilitators. Stanley Feld is now talking about physicians as coaches, patients as players, and then professionals as partners, and then professionals like my oncologist as the absolute authority. That's participatory medicine. Look when he did those slides. Right? January, February 1995. The Mozilla web browser came out in April of 94. This was less than a year after the web came into existence. He foresaw this. Now, in my day job, I work on technical trends. I've led a worldwide standards committee in the printing industry where I was working at the time. I have spent decades introducing technologies and seeing what succeeds and what flops. A really good thing to do is look at people whose predictions have come true. Tom Ferguson is one of those people. Will consumers poll? Well, talk about skating to where the puck's going to be. Here's the citizen trend. Just in the last 8 years, we had 46% of households were online in 2000. Now it's 74%. Another way to look at that is the fine print under that. 54% were not online 9 years ago, and now that's cut in half. So, the number of people who are not online is shrinking, plus the not onlines are largely the older people who 10 years from now, many will have expired, plus our kids who have been coming up, they grew up on email, will be the dominant ones. And the number who have access to broadband has gone from 5% to 57%. This is brand new data that Pew is just in the process of releasing. I urge that the policy decisions we make now be oriented toward where we're going to be in 2020. As Steve mentioned, on April 1st, I punched the button in patient site to move my data to Google Health. What happened then, as a result, ended up as front page news on the Boston Globe, because the first thing I saw with the center screen grab there is an urgent medication alert, the interaction of my blood pressure medication, and a condition that it turns out I actually had 2 years earlier when I was in the hospital being treated for cancer. And the conditions that were transmitted on the right side, this is what showed up in Google Health. Everything I had ever had got transmitted with no dates attached to it. And this is where the work that I do in marketing, with marketing data right now, I was able to say, I have had data transfers go bad, and I was able to sniff out what had happened. The end result was within a week, the hospital had decided to change its policy about how it was going to do this. My doctor and I also dug into the detailed records of everything. There was craziness in my medical data. You can see in the middle of the left screen grab, non-rheumatoid tricuspid valve disease. Well, that was when I was getting an infusion of Zometa for my bone met in my femur. It is not normal that an orthopedist would diagnose tricuspid valve disease. Cuckoo. And not only that, there is no way to tell how this data got into the system. Now, we know even in our simple marketing system, that you need to have controls. And because I'm running way too long, there are normal IT issues that we're going to manage. Let us not overlook. There need to be experienced IT experts involved in setting up the workflows. You have the issue of the selection of a data model. There's this principle, the seduction by the readily available. What was transmitted to Google Health was claims data. And I've since learned that claims data is notoriously unreliable. There's this practice called upcoding, where people will just pick the most expensive billable thing. And there's also the lack of the tracking mechanisms. There was another case where I had hidradenitis, armpit cysts, was diagnosed during an abdominal ultrasound. That was a pretty amazing abdominal ultrasound. There's fitness for purpose. There was data that was transmitted where I had gotten an MRI to check for bone metastases, for metastases to the spine and brain, but there is no separate billing code to say we were just checking. So what got transmitted was, this guy has this condition. That's cuckoo. We need to be double checking each other. I know health IT is a massive, complex subject, but we need to be double checking each other. And then finally, testing with real-world data. Patients can help. Thank you so much for your patience. I have so much I could and would say. Meaningful use must include complete patient access. We can find mistakes. We don't have to be doctors. For instance, that Minnesota family, you don't have to be a doctor to say, wait a minute, the cancer's in the left kidney, not the right one, right? And I'll tell you, even as a first thing, and this has nothing to do with health IT, this book contains an enormous number of just plain errors and orders that were issued and never carried out. For instance, an order was put in for a walker, and the family didn't know that. 6 weeks later, when they got these paper records, they found that out, and they could have said, wait a minute, didn't we overlook the walker? One of the first things I think we ought to do is just mandate that everybody at any time can walk up to the counter and say, let me see the records, and make copies. And obviously, when that's electronic, it'll be that much better. So please enable participatory medicine, because health professionals can't do it alone. Thank you very much.
Thank you. Thanks so much, Dave. So our strategy in the consumer community is we're going to clone Dave. And it'll be about 100,000 of them next week and spread them around the country.
I'll be having lots of fun then.
We have five or so minutes for questions, so I'll open it up. And please, again, a reminder to say your name. Laura.
This is Laura Adams, and I think this is directed mostly to Christine and Jody. We couldn't agree more with that notion of privacy as an enabler. For us in Rhode Island, we kind of went there first, and for us it has enabled so much. We've been able to move things forward, I think, far faster because we went there first. We're now, though, coming up against what will probably be one of our biggest challenges, and that has to do with the notion of teenagers and disclosures to, I noticed that got a reaction from all four panelists. I think that we're all feeling that. Can you comment on what you're learning there, what you know about that? Are you seeing any trends, anything that points us in the direction of a little bit of light at the end of this tunnel for how we're going to deal with that issue of the 16 or 17-year-old who doesn't want the family looking in on the pregnancy test or something?
So, and I'm going to ask Deven, I think, as well. It's a big issue. I haven't seen best practices. What I think we have, though, are policies, and I think the policies are different in different states, and so there's an interplay that we have to pay attention to. This is a hugely delicate and difficult issue, and so I do think it is an area, though, that lends itself to engagement and to talking with people locally, teenagers and parents alike, about what makes sense here, how we can thread that needle, how we can balance the rights and protections of minors against the needs of parents. So I think it's a hard conversation. I haven't seen it. I don't know, Deven, if you have.
No. I mean, the one thing I will say is please do not ask us to resolve this at the federal level.
Yeah, right.
Please do not go there. It just embroils this in all kinds of messy politics, which I think you guys are all well aware of. HIPAA largely defers to state law to resolve this. If you're old enough to consent to the care, you're old enough to have that information be kept private. And then, of course, the states are a little all over the map in how they do this. I've been actually approached, again, because I used to be at the National Partnership, so I'm really pretty acutely aware of this. And I've been approached by some HIEs about help us figure this policy out. And I don't think there's a one-size-fits-all solution, but definitely please don't ask for federal policy in this regard, because I can promise you they will mess it up. They'll make it worse than it is right now. But I think we do have to find paths forward so that states can have some models that they can use.
Kevin Hutchinson?
Can I just follow up just one?
Oh, sorry.
I just wanted to make the point that I think that while we may not want federal policy, I think we do want national consensus to the extent that it'll enable the nationwide health information network.
Kevin?
As we look at sources of data, and this is kind of a question for the whole panel, especially Dave, you try to find aggregation points to where you can at least get started with information exchange. And the payer-based data is an aggregation point where there is data that's available. Given the inaccuracies that, Dave, you've mentioned into it and others' experiences on the panel, would you completely exclude this concept of a patient payer-based record, or is it still a good place to start as long as there's access and ways to correct the information?
Well, that's a great question. First of all, I always have to say I really don't know squat about all the complexities of this industry. I don't claim to have answers. This is a hobby for me, right? Learning about all this. I have a day job and a family, and my physician, my primary, has ordered me to get sleep as well. So just common sense from my perspective as a somewhat naive consumer would say, let me get my hands on everything that could be useful. Now, as it happens, I've since learned that Health Vault has an approach that all the data you import comes into sort of a holding bin where you can pick through it and say, wait a minute, that's stupid, that's bad, no, I want to make a comment about this, and so on. That might work. In general, I'm in favor of getting my hands on any data that might help.